Hello, everyone. Nice to see everyone here. Welcome to WVU Walk with the Future Doc. We are joined today by Dr. Courtney Pilkerton. She's an assistant professor with WVU Department of Family Medicine. Yeah, great to be out here. What else do I need to say? I have a few things to say before I introduce Dr. Pilkerton, I guess, and before she kicks things off. First of all, this is going to be recorded. Specifically, the audio portion gets recorded and gets posted to our YouTube page. So by participating here, you consent to be recorded. So yeah, check out our YouTube page, WVU Walk with the Future Doc. We also have a Facebook page with the same name, WVU Walk with the Future Doc, where you will be able to see info for our upcoming walks. We also have a survey that we would like all of you to fill out once the walk is over, just to let us know what you enjoyed about the walk and if there's any areas for improvement. Yeah, so I guess with that out of the way, I'd like to formally introduce Dr. Courtney Pilkerton. Again, she's an assistant professor here at WVU Department of Family Medicine. She has some research interests in rural health and preventative medicine, so some especially important themes for our state. And she's going to be talking to us today about population health, about what it is and why it is so important to us. So yeah, I guess that's all I need to say. So I'll give it to you, Dr. Pilkerton.
I'm going to try not to drop this. Can everyone still hear me? Okay. I'm Courtney Pilkerton. I guess we'll start walking this way. So fair warning, I do love research and statistics. So there will be some bell curve discussion at some point. But I think first I just have a question kind of for the group. What do you think of when you hear population health? Sort of a new buzzword. So I'm curious.
Prevalences of certain diseases.
Okay.
I think about like how we go about doing screening as far as like different types of cancers and what age you start doing that depending on like how much the disease is prevalent in the population.
Excellent. Okay. Any other thoughts? Excellent. Okay. Yeah. So you guys have hit on a lot of the main themes of population health. It's even more specific now to individuals and will be more specific to how we practice medicine very specifically. So I'm going to start with kind of talking about some definitions, how we got here in terms of population health, and then some examples, and then just kind of let you guys ask questions or talk more or turn this into a political advocacy discussion. I don't care. There's lots of ways you can go with population health. So I'm going to start with kind of if I had to pick a textbook definition, I would pick basically health outcomes of a group of individuals and the distribution of health among those individuals. And so where did this definition come from? Well, essentially, think back to when none of you were alive in the 1900s. What were the top sort of diseases or killers or of people?
Infectious disease.
Right. So that was number one. What was probably number two? So it's injury. So that was it. So infection and injury. So we started out with infection and injury, and then, modernized society sort of helped us sort of prevent a lot of those infections. Some early public health, which I would say were population health things, sort of helped us prevent those things and improve those. And we started to see people living longer. When we saw that, we started seeing, people get heart disease, they have heart attacks, they get cancer, they get diabetes, sort of these chronic disease. And so we entered kind of that chronic disease era. So in the 90s, the question was, well, what makes someone healthy? And what makes a population healthy? And how can we keep everybody healthy? And so a lot of population health kind of stemmed from from there. And basically people were just trying to answer that question. What kind of makes someone healthy? And so a lot of the things that you guys mentioned, prevention, screening, those kind of things, all stemmed out of. But I think to understand population health and how it's sort of transformed over the last 40 years is to really think about what does it mean to be healthy? So the World Health Organization definition of health, I feel like people are usually very familiar with it in terms of well-being and sort of physical, mental. A lot of people add spiritual now, but the original definition just has physical, mental, and social well-being, not merely the absence of disease. So we're kind of getting away from that disease model. So even when you think about chronic diseases in populations, you know, a lot of people were like, no, it's not enough to just not have disease. We want you to be healthy. And so it's what can we do to support health? And so they were looking for determinants of health. So anyone have throw out some determinants of health?
Comes.
Yep. Excellent.
Access to like food and water.
Mm-hmm.
Shelter.
Yeah. So these are great. So we're thinking big picture determinants of health that are not just what's your blood pressure, you know, what's your cholesterol, those kinds of things. And so this is where I say every elementary student is a student of population health, because we all learn the social ecological model in elementary school. We all make that little graph where there's a picture of us in a house, and then we put our street around us, and then we put our town around that, and then we put our state around that, and then we put, you know, the country we live in, and then usually they have the earth after that. And so that is the social ecological model, and that's the basis for pretty much all of population health, public health. I have a lovely picture here if anyone wants to see. So this is sort of the research version of the social ecological model. So same thing you learned in elementary school, just with a lot of extra words. And so you're still the individual in the center, your family values, how you were raised, your own goals, all of that kind of surrounds you. Around that are the organizations like your school, your work, your faith organization. And then around that is your community, your neighborhood. How walkable is it? Where is there access to food? Is there access to water? Is there access to places to exercise? And then around that is the government with all of their policies and those kinds of things. So all of these layers impact health, and they interact with each other as well. And sort of initial researchers in population health were like, okay, which layer is the most important? That's what we really care about, right? Like we want to know which layer is the most important and how we can move health forward. And so that's where things like county health rankings come from. So every year the US News puts out a top 10 healthiest counties in your state, or top 10 healthiest counties in the US. And so they've actually, while very publicized, have a lot of great research on like what actually makes up health. So I have another figure that I will share these links. But anyway, so this actually is the research into all those things that we talked about and how each one impacts health and what percentage we currently believe these things impact health. So if we look at it, there's the physical environment, housing, transit, air, and water quality. And it's been shown that's probably about 10% of health. Clinical care, as in like access to a physician, access to prevention screening, all of those things that you think about a doctor's office, about 20%. Health behaviors, like whether you smoke or not, your diet and exercise, alcohol and drug use, sexual activity, all of those things, about 30%. And then those social and economic factors like you guys talked about, education, employment, income, family and social support, those things make up about 40% of what determines health. So that's sort of why you start hearing about social determinants of health. How can we impact those to impact health? And now they've even gone so far that the US Preventive Task Force actually just put out recommendations that in clinics, we should be screening for these things, not just your blood pressure, not just your family history, but we should be asking regularly about housing, affordability, transportation issues, and those kind of things, and looking for ways to intervene. So I talked exhaustively about the health part of population health. So what do we mean by populations? And so really, that's just a group of individuals. And usually within the research side of this framework, we're talking about total population. So we're thinking all humans, what makes you healthy? There's also, states are worried about people who are in that state and are they healthy? Hospitals are worried about the population that they care for. Are they healthy? Physicians are worried about their patient panel, or any healthcare providers worried about their patient panel. Employers are worried about the patients that have insurance through them because they don't want it to be expensive. So they want to focus on how can we improve the overall health of this population. So that's kind of where we get into population health. A little bit means different things to different people. We think about it as sort of this big total population. We're looking for like all the answers, but even on a small scale, to give an example, we'll take WVU. So they're an employer and they have lots of healthcare providers, facilities workers, all of these sort of different people that are insured by them. And what they care about is how can we keep our cost to a minimum and keep people at work. And so they focus on activities, wellness programs, and things that can sort of focus on those participants and do those things. So we call this more like population management or population health management or population medicine. So we're focusing on a specific group of people. But if we're looking in that small group, we're not necessarily looking for all the big answers because, as we know, a lot of those layers are outside of an employer. And so we're kind of looking at a much smaller microcosm of population health. So that's kind of just one example. Some of the total populations, we kind of went over that infection and injury. So since the 1900s, so over the last 100 years, we've actually increased life expectancy by about 30 years. 25 of those years are attributable to public or population health strategies, vaccination programs, seatbelts, tobacco sort of laws and regulations. So all of those things have contributed. Clean water, modernized sort of facilities, those kinds of things have all contributed to about 25 of those years. So you can see that population health can be sort of that big picture and it can be that very small picture. An individual physician taking care of patients, is now going to be examined on their quality of care, whether they're meeting, like what percentage of their population has a A1C under 9, blood sugars controlled, blood pressures controlled. And those things are looking at the population of patients they see, because we know that I can work really hard on a one-on-one basis with somebody, but that might not move the needle of money very far. But if I move everybody just a little bit, I can make a huge impact on the overall cost of healthcare. So I have lots of different areas that I can go into this. I don't know if anyone has questions or thoughts about specific pieces.
You want to talk to the microphone and I'll open this up?
Sure.
Just hold my phone. All right. Well, thanks everyone for joining us on Zoom today. My name's Mia, and I'm a third-year medical student here at WVU. So thanks for joining us, whether you're inside and walking inside on your treadmill, or whether you're outside bearing the rain like we are here. Thanks for getting out and being active on a Saturday morning. We're going to open it up now to questions. So if you would like to unmute yourself and ask your question out loud, you are welcome to do that, or you can send your question through the chat. And we will make sure that your question gets answered. We also have a good group of medical students here, along with Dr. Phillips, to just kind of ask some questions to Dr. Pilkerton and keep the conversation going. At the end of our walk today, we're going to release a survey through the chat just to kind of see how our program's going, how it's benefiting our participants, and see what else you guys would like to hear from. So I'll pass the microphone back to Dr. Pilkerton, but I want to start her off with a question. How is population health different on a national level compared to like the needs of our state of West Virginia?
All right, so that's a great question. And it's one that every employer, every policymaker, and every physician asks themselves is sort of, where can we intervene? And so on the national level, usually we're talking about large policy changes. Can we figure out how to make the inequalities between certain groups less so that everyone sort of has a healthier shot? So there's not certain people that are now at higher risk and using more healthcare dollars. On a community level, we might just be, thinking about, wow, we really have a lot of people with diabetes around. How can we help them who we know who help run our, local coffee shop, or, run our, dog grooming place, like, our community members, our family members, how can we help set up healthy as the default is what kind of we like to say in public health, so that you're not asking people to make individual choices. You're helping set it up so that the environment's healthy. The healthy choice is the easy choice. Making an unhealthy choice is a little bit harder. You got to pay more for it, or you got to do something else for it. So all of those decisions are things that you can do at a local level on a small scale, whether it's starting a group like this, where you just get together and walk, improving exercise, exposing people to social support group, those kinds of things. Or on a national level, whether you're trying to get a soda tax so that sodas are more expensive than water or another healthy option. So yeah, it kind of varies what your target is. And I know you guys have had kind of a talk with advocacy, and so population health kind of gives you the data for all of these things. So it gives you the data for advocacy. It gives you the data for what you should be doing about nutrition, what you should be doing. Like some of you said, like the screening that we do for colon cancer, breast cancer screening, all of the data behind why we do those things is all because we looked at populations and said, wow, this is the rate of this. And if we screen them, we can catch them early and treat them better. So all of that is supported underneath by population data.
I have a question in the chat. Can you read
I
the
will.
second one, the middle one?
Second. All right. This is Dr. Davison. She's asking about the difference between public health and population health. Yeah. So yeah, I was going to say that's a really common question. And I would this one is a little bit controversial. So I think everyone has a little bit of their own opinion on this one. Obviously, these are, not your typical dinner conversation arguments, but for some people they are. I would like to argue that population health is really sort of the new format of public health. So public health has usually been targeted at total population. And so looking at the total population, whether it's local health department who's responsible for the health of their county, whether it's the Department of Health and Human Resources for the federal government, who's responsible for, the nation's health. I think that really public and population are the same thing. It's just that public is usually referring to total population and not necessarily some of the new areas of population health that are really focused on, what can an employer do to support the health of their employees? What can an individual provider do to support the health of their patient population? I think it's just sort of a little bit of semantics with the word, so that public to me usually means we're thinking total population.
A little bit of distinction earlier, that's why I was curious.
Yep.
Yeah, just pass the microphone to Michael, or just repeat back your question.
Okay, well, it's a bit of a complex question, so I'll use the mic. So I understand that the social determinants of health should be a major factor for like government, whether it's federal government or local government, to focus on. But my question is, as far as individual doctors meeting with their patients, like one-on-one, how much should these social determinants actually be discussed? Things like housing and income. And the reason why I ask is that, patients, they can control whether they take their meds. They can control, what they eat, sort of, right? But they might not feel that they can control their income and their housing situation. And so, do you think that it would be good for individual doctors to focus on this meeting with their patients, considering that some of these factors might be out of their patients' control?
So great question. I think this sort of gets at the idea that resources are finite. And so there's always going to be an argument about where should any individual person or group spend their time and money to make the biggest impact. And so I agree that in a general primary care visit where you've got 15 to 20 minutes to go through a whole list of things for sometimes really complex patients with a lot of chronic health conditions, that bringing up some of these social determinants feels a little futile, because you feel like, what can I individually do if they tell me that these things are an issue? But I would say that in some cases, healthcare providers do this already, because you ask, do you have issues affording your medication? What are your transportation issues to get to the office today? So these are all kind of getting at that sort of greater sphere of things. In family medicine, we also do home visits. And I think that makes it startlingly clear sometimes why a particular individual is struggling to get some of their health under control, because they may not have access to all of the things that you thought they did until you see their home, you see where they live, you see the barriers that it would take for them to get healthy food or transportation to get to a clinic office visit. So I don't think, on the day-to-day that it's necessarily that, every provider should be making sure they're asking these questions. But one, if we don't have the data to show how big the problems are, no one's going to fix them. And also we won't see the patterns. So it may be that a community, you start noticing that everyone has an issue with a certain particular transportation. And then you can advocate to the system, like, how how much money we could save if you could actually fix this transportation so that people could get here. And so sometimes that does matter. That actually happened here at WVU. So there were a lot of issues with getting some of the Medicaid or other services transportation. So actually WVU population health management team developed a system where they can get reimbursed for Uber rides to get to clinic appointments, because they recognize that if you can't get to the doctor, you can't make adjustments on your own health. So I think that, that was providers in clinics that noticed that problem and tried to address it at a population level for a community. And so, you can't spend all 20 minutes when somebody comes in with a blood pressure of 180 over 110 and an A1C of 11. But I think that it probably underlies a lot more of why those things are uncontrolled than people realize.
Unless you want to go to one in the chat.
Go ahead. Okay.
Uh,
Hold the microphone.
So you mentioned several times that you really enjoy looking at data and research. Where do you think that the biggest frontier with research is in population health?
So I think I think currently one of the biggest innovations and frontiers in population health is electronic health records. So we have access to population data in a way that we have never had access before. However, none of those systems were meant to collect data on populations. They were meant to collect data on an individual for a documentation and legal purpose, not for a research and for billing. That's right, Dr. Phillips. They were not meant to collect population data, but more and more we are learning that that data is invaluable and really helps us make, and that's, you're seeing departments, hospitals create population health arms specifically because of data that they've gotten from electronic health records that they just didn't see before. I think sort of the next wave of frontier would be if any one of you lovely smart minds can figure out how to integrate health records between different health systems so that we can actually identify people's use of health services. So, right, yeah. So let's even give a bigger population example of like human trafficking. So you see that, there are patterns of emergency hospital use, urgent care use that often people who are stuck in human trafficking use. But because we're so fragmented in our electronic health record system, you can't actually identify them, because in your system, it looks like they've only been to the emergency room twice when they've probably been 25 times to different urgent cares. And people are smart, so they figure these like loopholes out. So I think the integration of health records is absolutely one. I think the other arm of it is just making the documentation process that physicians do, it's decreasing that burden for any one provider so that there's more time to actually talk about things with your patient, but that there's also more standardization in how data is collected so that we can actually use it for research on the other end. Because maybe, I'm just going to pick on Dr. Phillips, maybe Dr. Phillips writes long paragraphs in every single one of her clinic notes, and I click on a lot of the buttons. My data is stored in the electronic health record as individual things, whereas her data is stored as a clinic note that somebody is going to have to read to extract actual data points from. And so I think from my mind and sort of the research realm, those are kind of the big things that we have to work on in population health, is getting that data. The other thing is there's still arguments about how we should tackle population issues. So we've been really focused on high risk populations. So let's take BMI. So let's take obesity. So this is where the bell curve discussion comes in. So if everything was perfect and we were in a classroom, most of the kids would get C's. We'd have some overachievers getting A's, and we'd have a few who are struggling over there with some F's. So we've got that nice bell curve. Well, BMI looks just like that. We've got a bunch of people, depending on your state, they could be clustered around overweight or normal weight, hard to say. And then you've got some people with very high BMIs, a lot of obesity, and then at the other end, some underweight individuals. And so what we've done most typically is said, I want to take all those people who have the highest BMIs and throw them back in the middle, like fix that high risk. So you're taking that bell curve and you're just trying to chop that end off and throw them back into the middle. And while you do affect dollars and quite a few people, you're still only dealing with a very small high risk population. There's a lot of work based on Rose from kind of the 1940s and 50s that suggests what you should really be trying to do is move the whole bell curve over. because then you've shifted everyone in the population over just a little bit, but you get actually typically more cost savings because you've moved everybody and you've usually set your systems up better to affect change. The other kind of version of this bell curve is in taking both ends, the low and the high, and trying to stuff them into the center so that you basically get a rectangle and not a bell curve, so that everyone is at a normal. And then you can kind of intervene on that. So that's kind of the other, I think, as a population health study, we need to kind of figure out what are the most cost-effective ways. And it might not look the same for every disease. So for diabetes, maybe shifting the whole curve is important, but maybe it is just the high-risk individuals that are going to save the money. And so those kind of things we won't know unless we have the data to track them.
A couple seconds going on, trying to turn the volume down.
Of
So
course.
sorry.
No. There we go.
Can you read the top question? from
I
Dr. Neal?
will. So Dr. Neild, can you comment in more detail about the effects of racism on population health? Yes. So I love this question for lots of reasons. And one of them is that population health in general is how we started to see a lot of the inequalities in health, whether it's racism, whether it's gender-based, whether it's income-based, any of these. When you start looking at a wide range of people and a wide range of health outcomes, you can see how lifetime stress, like in racism, where you kind of you're always concerned, you kind of have this increased stress level, and it impacts everything you do. It impacts your access to care, all of those things. We see that your health goes down. With income, we see that at the low end of that bell curve, where people have the lowest incomes, just even a few dollars makes a huge impact on health. Whereas at the top side, increasing income almost does nothing. They can already afford kind of basic care. So increasing dollars there. And so it really does highlight where the inequalities are when you take a look at populations. And sometimes we'll kind of elucidate ways that you can make change. I think one strong push in population health just with the COVID pandemic has been that the resources that have gone out inequitably. So some countries got vaccines early because they could afford them, some don't have them. And kind of what has happened live time with cases and health has kind of shown that, if you're just looking at high risk populations, you might actually make inequalities worse. So if you're focused on income, and you try to increase everybody's income, you're probably going to move the bottom up a little bit, but you're going to move the top up a lot too. So you're going to either keep the system the same or you're going to make those inequalities worse. Racism specifically tends to be a little bit more difficult because it permeates every level of that social ecological model, and it interacts with the different levels differently. So there's the very real stress on an individual level. There's organizations that were set up for not you, really, to be honest. And so you not only have your own risk factors increased, but then at every level that you're interacting with the system, your experience is different than somebody else's. So it's population health data that lets you see those things are going on. And then it's, where can you start making those interventions into the system to try to make that equality of care and access. Dr. Neild, I hope that answers. Yeah. Yeah. Do you have Do you have suggestions on how to ask patients about effects of racism? So I don't know that I have a whole lot of really good like tutorial style suggestions, but I would say that I'm a primary care provider. I went into primary care because I enjoy people's experiences, their families' experiences, and working with them as a group. And you develop a relationship with your patients, and you can do this in specialties. A lot of specialties see patients. If you have heart failure, you're going to see your heart doctor for the rest of your life on scheduled intervals. When you're pregnant or in your sort of family building phase of life and you're seeing OB care, you're going to see providers on repeat. And it's really, I think, the relationship building with your patients that lets you be able to ask those questions and lets them feel comfortable bringing issues up to you. And sometimes you're unaware, and we should all be open to the fact that, we all have unconscious bias, and you don't even recognize that you haven't asked or you haven't dealt with something. And then I've found that patients who feel really comfortable with you after kind of building that relationship will sometimes say like, hey, I can't get access to this program because of the color of my skin. Or, I just really want to tell you that like the reason I can't afford insurance is because I lost my job because they chose to give it to someone who was white, or those kind of things. And those are all like actual things I've had patients say to me, both of those. So, it's really, I think, about that relationship building and what makes the individual part important. And I think that's the thing to remember is medical care was built to treat and diagnose, and sort of that public health, population health was sort of meant to prevent, but the lines are getting blurred. And so it's really important as healthcare providers in training, or healthcare providers that are always in training, that we continue to try to help our patients in any way we can. And knowing that those determinants of health are wide ranging, and that the actual medical care we provide is really probably only impacting 20% of their health. I think that's what's important to keep in mind, that some of these bigger issues are probably impacting individual health more. Sorry, that was kind of soapboxy.
Side topics that you want to dive into today?
Side topics.
Maybe we could just do like a more specific example.
So can we talk a little bit about how we apply population health? So maybe we can use the example of like breast cancer screening. Like, why do we only start at a certain age when like any young people get breast cancer?
Sure. So I think that's a great question. So you're kind of getting at like, let's walk through a very specific example of how population health got us where we are, and how if you had a question, you might be able to change kind of screening guidelines or something like that. So breast cancer screening, most cancers are on registries. And so they're tracked at the population level, how many people have certain types of cancer. There's also been large, studies like NHANES or the Nurses Health Study that have looked at populations over time. Who develops cancer? When do they develop it? What treatment did they receive? What were their outcomes? How did things go? And so all that information is analyzed, and they sort of come up with, okay, so most people on a population level develop cancer between this age and this age. And our treatments work best if we can identify it at this age or this age. So we know that, when you get older, you've lived more years. There's lots of things that have happened in your life that might put you at higher risk for developing cancer. But screening 80 and 90-year-olds for cancer that is, probably already there might not be as impactful over the course of a lifetime as screening 20 and 30-year-olds and being able to treat it early, as well as give them productive work years back to their life. And so that's sort of the harsh data side of how these things are looked at. They also look at the harms from the screening. So if you identify a suspicious nodule in a 12-year-old's breast and do a biopsy on it, most likely it's not cancerous, and you have, put someone through a procedure, probably terrified that poor 12-year-old. And so it becomes that the risk of sort of the procedure or the screening just isn't worth the benefit of catching maybe one case globally a year or something like that. So a lot of those screening guidelines are all built on studying populations. I'll bring Dr. Neald's point up about racism and some of these other structural things. What population you study impacts what you find and whether it actually applies to other populations. And so for a long time, we've studied majority white male populations. And so we end up with white male data, which means that we apply screening guidelines across lots of populations that actually don't apply at all. And so that's one thing to keep in mind with any kind of screening guideline is what's the data underneath of it. And part of the reason why you're seeing breast cancer screening guidelines and colon cancer screening guidelines change to screening earlier is because by nature of a lot of the chronic diseases that we're seeing earlier and earlier, we're noticing that cancer rates in younger populations have been going up. And so we're having to screen earlier so that we can offer treatment earlier and hopefully give them back more years to their life.
I think we're gonna wrap up a little bit here. All right. Well, thanks so much, everyone, again, for joining us on Zoom or whether you're here in person. We appreciate you and we love seeing you out and about on a Saturday morning. We're going to kind of wrap up the talk shortly here. I'm going to ask Dr. Pilkerton to think of 3 takeaways from her talk today that she'd like for people to know. And I want to let everyone else know that we are going to be releasing a survey right now in the chat. I think Parag is going to post it for us. We ask that you take that survey within 24 hours of the talk. So you could open up the link now and save it to do later. We just want to hear your feedback on how our program's going, how you received the talk today, and what you'd like to hear from in the future. And we're going to release the survey at the end of every walk. It'll be the same length, but we just ask that you continuously keep filling it out so we can see how we're doing over time as more people continue to come to our walks. And the survey is supposed to be anonymous. So we encourage you to take it. We'd love for your feedback on our program. So I'm going to pass the microphone back to Dr. Pilkerton. I think we had some great questions from the chat and from our medical students here today. So Dr. Pilkerton, can you give us 3 takeaways from your talk today?
All right, I will attempt to come up with 3. But I think the first one is that population health is a growing impact in healthcare, and that even if it's just, what you're going to get paid for, when a patient comes through, or is it, the next COVID pandemic, is it, whatever, that the lines between sort of what we think of as traditional one-on-one patient individual conversations, and we think of then public health as that sort of they take care of the population side of things. That's just not the way it is anymore. And that you're going to be responsible for a population and that, you know, even if you're not a healthcare provider, you're a part of a population, you're a part of a community. And so those lines between health and population are blurring. And so really having a good understanding of all of the determinants, I think, will become more important. So that's kind of one, is think about healthcare as bigger than just the individual conversation you have with a patient. Two is that research and data are only as good as the design of any study. And so we like to take screening guidelines and all of those things as absolutely like, huh, the experts have told us. But the experts are just looking at data, and you don't know what the data that they're looking at always is. So if something doesn't match your experience, something doesn't match your patient's experience, or if you're just like, that's weird, you know, it's always good to look deeper and find out, like, who are the people this was studied in? Are we missing populations that could be important? And then I think my final sort of takeaway is that there is more than blood pressure and diabetes that impacts any one of us as an individual. And we talked about health being sort of that state of well-being, not merely the absence of disease. And remembering that a lot of these social determinants of health, environmental and policy things, actually have a lot larger impact on our health and our patients' health. And so making sure that we're not discounting that some of those may be, you know, creating an issue for patients that we might be able to help with, sort of like transportation.
All right, any like final comments from the med students here? All right, well, I think we're gonna wrap up. Thanks so much, Dr. Pilkerton, for joining us today and leading a great conversation. I think this is something that we haven't talked about at any of our walks before, so it was really nice for you to educate us and share your knowledge and like love for all things population health and preventative medicine. If you have the chat open right now, you can probably see the survey link that Parag posted. We also are trying to see how far our program reaches. So if you wouldn't mind typing who you are and where you're walking from, we love to see familiar faces and names, but we also love to see the new people that are joining our walks. So again, thanks so much everyone for joining us. Our next walk will be in 2 weeks. It will be with one of our dietitians, Judy. So we're gonna get back to like nutrition and wellness talks for the next one in November as we roll into the holiday season. So again, thanks so much everyone for joining us. We had an awesome group today, bearing through the rain and the wind at one point. It was so strong. But thanks so much everyone for joining us, and let's go Mountaineers.
Yay!